Good morning. My name's Alan, Chief of Health Affairs. We're pleased to today, actually yesterday, but today have an event to release the October 2014 issue, Specialty Pharmaceuticals Spending and Policy. One of the risks when you are in publishing is that you have to begin planning a topic a year out, maybe a little more than that, and you always wonder if people will still be interested in the topic a year later. I think this is one of those times where we hit it just right. We could not have planned that 60 Minutes would run a segment on this very topic just this weekend, and the overall issues of course, healthcare spending are high on the agenda, but pharmaceutical spending and specialty pharmacy as well. Our unique contribution as a peer-reviewed scholarly journal is to not just talk about what's going on, but to provide new evidence and new analysis subjected to peer review and criticism, and that's the product that comes out in the journal, and those are the articles that we'll be discussing today. It takes a lot of work to put on an event like this and to put together an issue like this. We were fortunate to have the sponsorship of CVS Health to help underwrite the issue. We're also, we always tweet our events. Our account is at Health Affairs with an underscore between health and affairs. And today we're using the hashtag HA_specialty drugs. Feel free to tweet. Everything here is on the record. The opportunities that we will be discussing today, illuminated by the evidence of the issue of the articles in this issue, are how do we balance the incredible promise and clinical and medical advances that specialty pharmacy represent with the policy challenges, how to pay for them, how much to pay for them, how to make them affordable to those patients who need them. It's a classic healthcare conundrum, but we are right at the forefront of it as we deal with it in the area of specialty pharmacy. We've broken up the discussion today into three categories. Our two opening papers address the topics of cost and value. We'll then move into a series of policy issues, each of which are discussed in a paper in this volume, and then we'll have a conversation that's a little bit more far-ranging about the role of specialty pharmacy moving forward. So to begin our first panel, we'll be hearing from Rena Conti, an assistant professor of health policy in the Department of Pediatrics, the section of hematology and oncology at the Department of Population Health Sciences at the University of Chicago. She'll be presenting on trends in spending and the use of oral oncologics. And we'll then hear from James Chambers, who's an investigator at the Center for the Evaluation of Value and Risk in Health in the Institute for Clinical Research and Health Policy Studies at the Tufts Medical Center. He's also an assistant professor of medicine in the School of Medicine at Tufts University in Boston. So let's begin with Rena.
Good morning, everyone. It's an honor and a privilege to be here today. Today, I'm going to talk to you about some work that I've done with my colleagues on how spending on oral oncologics or oral anti-cancer drugs has outpaced that of medical care spending more generally. Previous authors have suggested that we are in a period of mitigated spending growth on healthcare generally as compared to GDP. But also, we are in a period in which spending on prescription drugs also appears to have been mitigated in growth. Furthermore, spending on the new prescription drug benefit offered by Medicare, Part D, has also appeared to both exceeded expectations in terms of both level and also trends in spending. We were interested in examining growth and also use of oral oncologics that are recently advanced into the US population. We're interested in this because there has been rapid growth in the development of these therapies following extraordinary advances in genetics and in immunology. No previous study has examined trends in both spending and also use nationally among this drug category. We used IMS Health's data called a National Prescription Audit, using tracking trends in both spending and use. Spending is in the red bar, blue is the use bar, among national prescriptions of oral oncologics from the first quarter of 2006 through the third quarter of 2011. There are three notable findings. The first is that spending on oral oncologics amounts to approximately $1.4 billion per quarter in 2011. There's also been a dramatic increase in spending on this drug category, amounting to approximately $2 million per quarter, or approximately a 37% quarterly growth rate over this time period. We also see trends in increases in the use of these drugs, but the growth rate is quite dramatically less than spending, amounting to approximately 10% over this time period. We decompose these spending and use trends into three categories that are drug-specific: mechanism of action or therapeutic class, whether the drug was offered as patent protected or not over the time period, and whether or not the drug was offered and covered under fee-for-service Medicare's Part D benefit, the pharmacy benefit, or under Medicare's Part B benefit, the medical benefit. We find that spending appears to concentrate among these four drug categories. This implies that spending is in part being driven by technological change, particularly among drugs used to treat selected blood cancers. When we compare the growth rate of these drugs to that of use, we find that use has also expanded quite considerably over this time period for these selected drugs. However, the magnitude of the use relative to the spending growth is always lower, and this implies that price increases among specifically these category of drugs is also likely driving some portion of spending growth over this time period. In sum, we find that spending on oral oncologics amounts to approximately $1.4 billion per quarter, or approximately $6 billion in a given recent year. This amounts to approximately 1/4 of spending on all oncologics, infused, injected, and orally formulated in a given year, but also amounts to approximately 2% of total spending on prescription drugs over this time period. Furthermore, our growth rate, the growth rate for these drugs, appears to outpace that of general medical care spending, that of prescription drug spending more generally, and appears to be driven both related to technological change, which likely has benefited many selected patients, but also is being driven by price increases that likely have more ambiguous welfare implications. Thank you.
Okay, first, thank you very much for inviting me to speak today. In this research project, we scrutinized the value of specialty drugs and tried to better understand whether the costs of specialty drugs are worth the benefits. This research was supported only through internal funding. So what do we do? Our research pertains to drugs approved for the first time by the FDA from 1999 through 2011. And we took a systematic approach to comparing the value offered by specialty drugs with the value offered by traditional drugs. In other words, we examined if the cost of specialty drugs are truly worth the clinical benefits. So for this work, we classified each drug with respect to specialty status using the specialty drug lists issued by CVS Caremark and Express Scripts. Okay, so what we're trying to do here was try to evaluate the impact of the new drug in terms of health benefits over existing options and also additional costs. So it's the impact of this new drug relative to existing therapies. For each drug, we performed a literature search to identify estimates of additional health gain measured in quality-adjusted life years, or QALYs, and additional costs relative to a comparative treatment. The majority of estimates originated from cost utility studies, which are cost effectiveness studies, Although we also included comparative effectiveness research studies reporting clinical benefits using QALYs. And we only included cost utility studies that were not funded by industry here. So we screened the literature and only included those that were either unfunded or funded by a non-industry source. We use QALYs because they account for drugs' effect on life expectancy and quality of life, and therefore can be used to measure the efficacy of all drugs and also allow us to compare and contrast drugs across different indications. An important point is we considered all additional costs associated with therapy. That is drug costs, hospitalization costs, and all other drugs, all over costs that would be associated with treatment over the duration of therapy. So to emphasize, what's reported here is not just drug prices, but rather the total cost of using that technology. Key to this research was that we attempted to include only estimates of health gain and costs for each drug relative to standard of care at the time the drug was approved. Therefore, we excluded studies that compared our drug of interest to placebo or no treatment if it was apparent to us that there was genuinely an active comparator available at the time that the drug was approved. We also included studies that for which the included comparator was approved after our drug of interest. So for a drug approved in 2005, we excluded studies that compared that drug with other drugs or technologies approved after that date. And when a study compared a drug to multiple alternatives, we included reported health gains and costs relative to the most effective alternative available at the time that the drug was approved. So in cost utility studies with multiple alternatives, we chose the alternative that was most effective and that was available at the time the drug was approved. So in summary, we built a data set of the additional health gains and costs associated with approved drugs compared to available care at the time of drug approval. In other words, we identified the additional costs and benefits of new drugs compared to older drugs. And our data set included 102 drugs, 58 specialty drugs, and 44 traditional drugs, which is approximately 40% of all drugs approved from 1999 through 2011. Okay, so what did we find? Well, first we found, unsurprisingly, that specialty drugs were associated with higher costs than traditional drugs. And again, to reiterate one last time, reported here is not just the drug price, but all costs associated with therapy. So this accounts for reduction in hospitalizations and other costs that would be incurred associated with that treatment. All traditional drugs were associated with additional costs, so additional costs over pre-existing care of $25,000 or less. In comparison, roughly 1/5 of all specialty drugs were associated with additional costs of greater than $50,000. The median additional cost for a specialty drug was around $12,000 compared to $800 or so for a traditional drug, which I think you'll agree is quite a large difference. So our findings really do emphasize that care with specialty drugs is often much more expensive than it is with traditional drugs. But I guess we knew that already. Second, an important finding was that we found specialty drugs to be more effective than traditional drugs, and in some cases, notably so. So the median quality gain, so quality adjusted life year gain for a specialty drug was 0.2, which is equivalent to roughly 10 weeks of good health. And this compared to a median quality gain of 0.002 for traditional drugs, so very small. And one reason for this is that many traditional drugs offered no benefits over existing care. So it was a negative or a zero quality gain. You'll note that, unfortunately, the laser doesn't really work with the bright screen, but you'll note that the vast majority of traditional drugs were associated with health gain of 0.3 QALYs or less. So that's towards the top of this figure on the y-axis. While various specialty drugs are associated with relatively large quality gains of greater than 0.3 QALYs. Okay, so takeaway there is that specialty drugs appear to offer much larger benefits in some cases than, certainly not all cases, but in some cases relative to traditional drugs. However, a more sobering finding is that almost 1/3 of new drugs, irrespective of drug status, specialty drug or traditional drug, were less effective than older drugs. So 1/3 of new drugs are actually no better than existing care. And of drugs that did offer health benefits over existing care, approximately 1/3 offered less than 0.1 incremental QALYs, which is approximately 5 weeks of good health. Okay, so as a reminder, an objective of our work was to compare the value of specialty and traditional drugs. This third figure shows that when considering value for money, we found specialty and traditional drugs to be broadly similar. That is, we did not find a statistically significant difference between drug types. What is reported here is the ratio of additional costs and additional benefits of the new drug. Okay, so we look at the y-axis here. So $25,000 is the cost effectiveness. So it's the cost effectiveness of a particular drug would be $25,000 per quality adjusted life year gained. Closer to the origin, as this number increases, these are less cost effective drugs, with drugs costing up to $300,000 per quality adjusted life year gained. So you will note a different distribution of findings for specialty and traditional drugs, with specialty drugs associated with the highest incremental cost effectiveness ratios that were the least effective. But nevertheless, and this is the key finding, in aggregate terms, we didn't find a difference in terms of value when comparing the two classes. So in summary, while specialty drugs tended to be more expensive than traditional drugs, they also tended to offer much larger clinical benefits. And when considering cost effectiveness of value for money, they were broadly similar. So just to reiterate the key finding here. So our key finding is that while specialty drugs are more expensive than traditional drugs, many offer larger health benefits. Thus, in many cases, despite their high costs, specialty drugs can offer reasonable value for money. Now, it's important to note that this study does not address questions of affordability, but it does emphasize the importance of finding a way to pay for effective specialty drug treatments and ensuring that patients who would benefit from them have sufficient access. Thank you very much.
We have some time for questions. I'm going to start, Rena, with you. The overall finding is quite dramatic. In the paper, you look a little bit at Medicare Part B, D. You look at brand versus generic. Can you just expand a little bit on how those dimensions relate to the overall findings of growing costs, growing spending?
Yes, thank you. There are two findings that are notable. First, the vast majority of these drugs are covered under prescription drug benefits, not under the medical benefit of either traditional fee-for-service Medicare or commercial insurers. Secondly, we found that spending among drugs that underwent generic entry during our time period declined dramatically, and at the same time, use expanded. This suggests that, like other drugs in the primary care setting, when these drugs experience patent expiration and generic entry, they are used in the clinic, and that policy change probably provides quite significant cost value for money or patient value for money over time.
Thank you. James, similar to Rena, the aggregate findings are quite interesting, and then the question is, where do we go from here, because the range is so large for both specialty and traditional drugs? Can you, what would be the next level of inquiry that would be appropriate based on your findings to help the country figure out the policies around affordability and payment and value for these new drugs?
It's a very good question. Certainly, yeah, I mean, we found a wide distribution in terms of incremental benefit and incremental cost. I think there's a lot of scope for society and healthcare to really better understand which drugs do offer the larger benefits, irrespective of whether those would be traditional drugs or specialty drugs. And of course, there's established methods to do this. It's just in the US, we tend not to use those methods to inform decision making. I did note in my slides that a third of new drugs didn't offer any benefits, and of those that did offer benefits, many offered small benefits. Now, it maybe emphasizes that it is really challenging to develop new drugs, and maybe, you know, it's worth those drugs in order to get to develop the drugs with the larger health benefits. So I think there's a wider discussion of how we can stimulate innovation while ensuring that we do genuinely make sure patients have access to technologies that will truly benefit them.
Thank you. Let's get the microphones into the audience, please. wait for the microphone, stand up, identify yourself, and we'll get a few questions in.
Lisa Epano-Davis, LED Enterprise. I had a question for James. How did you conduct your study if you excluded all industry-sponsored studies? Aren't most of the clinical studies industry-sponsored?
It's a good question. So I looked at cost-effectiveness studies. I didn't look at clinical studies. So these are cost-utility analyses, essentially. Although I did include comparative effectiveness studies that compared active comparators using quality-adjusted life years. The cost-utility literature is a mix between industry funding and non-industry funding. While most studies, our sample would have been bigger if we included industry-sponsored studies, but we did have quite a sufficient sample of non-industry funded studies. The reason we included non-industry funded studies is because there's some evidence to suggest that if the manufacturer sponsors the cost-utility study, the findings would be somewhat biased, or could be biased. So we excluded those industry-funded studies to try to get our best estimate of relative effect. So it's just to emphasize, it was the economic literature that we relied on primarily here, not the clinical literature, which is why there's so many non-industry funded studies.
I see a question in the back. Again, identify yourself as you stand. Microphone's coming.
Dr. Martin Wasserman, Provider Resources, former Maryland Health Secretary. Help me just understand, if I'm hearing you correctly, that what we're talking about here is an optimal benefit of 10 weeks of additional life as the outcome and benefit compared with no difference by traditional drugs? Is that what your findings suggest?
Well, our findings were that on aggregate terms, specialty drugs offered much larger benefits. So there's no optimal value or quantity of quality gain. I mean, the more quality is the better. I mean, there's one treatment, Exjade here, the largest quality gain we had in our sample was 4.2 qualities, which is, a large amount of health. So we were looking at the magnitude of quality gains across specialty and non-specialty. Now, whenever we accounted for cost in this equation, we found that in terms of value for money, there was no significant difference between specialty and traditional. So just to emphasize that, so there was a statistically significant difference when we looked at cost. So specialty drugs were, in aggregate terms, much more expensive than traditional drugs. Though we also found there was a statistically significant difference in terms of health benefits. So whenever we look at the ratio of those two, we find in aggregate terms there was no statistically significant difference in terms of value for money, although there were some specialty drugs with incremental cost-effectiveness ratios far and beyond those traditional drugs.
Sure, but what was the significance of 10 weeks? What did that represent?
That was merely the median value. So it was the median amount of quality gain for specialty drugs. And
so when we're making policy decisions, how do we respond to the 10-week median value? How are we supposed to react to that?
It's a very good question. How do we value health in society is probably, I believe, one of the biggest challenges when evaluating medical technology. Other countries have an explicit value for how we should value equality. So therefore, how much are those 10 weeks actually worth to society? It's a very controversial topic. My colleague Peter Newman published an editorial in the New England Journal of Medicine a month ago, maybe less than that, which scrutinizes just how do we interpret any magnitude of health gain and what is reasonable value for money to society. It's a very difficult question to answer.
So my question is for Dr. Chambers, and it's actually sparked.
Go ahead and introduce
by the previous John Graham from the National Center for Policy Analysis. The question of not considering industry-funded studies. So did that mean, and if you said this, please forgive me, did that mean you had to get rid of 50% of the original set, or 80%, or 20%?
I would need to go back to check. It was approximately 55, 60%.
Right. And then can you describe who the funders of the studies that you looked at were?
Yep, they're often not funded, they're unfunded. The majority of them were funded through foundations. Some were funded from government bodies, so if there's an AHRQ study that was published, it would be in there. I should also say we looked at studies across the globe, so if there was a nice health technology assessment, we used that as well, which meant we had to convert and inflate the dollar value, which does, I should say, you should interpret the dollar value with some degree of caution, because we did have to convert and inflate that figure to 2013 values.
One or two more questions if we have them. Go ahead, down here. Let's go.
Hi, Mariella Payne with Ascension Health. What determines whether a drug is classified as a specialty drug? What's the criteria and who makes that determination?
That's a great question. So CVS Caremark helped us in that regard, and that they and Express Scripts publish specialty drug lists for their enrollees, and we considered a drug to be a specialty drug if it was included on either Express Scripts or CVS Caremark's specialty drug list. But you're right, there's no defined set of criteria for what is a specialty drug. I should have said a specialty drug is typically a large molecule biologic. It's an injectable, it's administered in a hospital setting. A traditional drug is typically available through your high street retail pharmacy.
And Rena, just to be clear, you disaggregated, but you didn't use the specialty, non-specialty distinction. You had some other distinctions, is that right?
That's correct. We use the anti-cancer drug category based on the World Health Organization's anatomic therapeutic classification.
One more if we have it. If not, thank you to our two presenters. Okay, we're going to begin with our second panel, which is covering a series of policy issues that are raised by the growing use of specialty pharmacy drugs. We'll hear from Steve Pearson, the founder and president of the Institute for Clinical and Economic Review, or ICER, which is an independent nonprofit organization that evaluates evidence on the value of medical test treatments and delivery system innovation and uses that evidence to improve patient care and control cost. We'll then hear a paper presented by Erin Kesselheim, an associate professor of medicine at the Harvard Medical School, a faculty member in the division of I'm going to butcher pronunciations here, pharmacoepidemiology and pharmacoeconomics in the Department of Medicine at the Brigham and Women's Hospital. We'll hear from Pat Gleason, the Director of Health Outcomes at Prime Therapeutics, and once again from Rena Conti, who I introduced earlier. She's an author on two of the papers in this issue. So we'll begin with Steve.
Good morning, everybody. Good. So the paper I did is with a research fellow at the bioethics department at the NIH, and I have to be very clear that the opinions presented in the article and today are not those necessarily of the National Institutes of Health or the Department of Health and Human Services. I like this topic because it has a gut feel to the person on the street. This idea that there are coverage policies out there that require them to fail something first before receiving coverage for what they and their clinician may want. And although that seems kind of clear, a lot of patients who have not experienced this, or clinicians, step therapy, even though it's been growing rapidly recently, it's still relatively poorly understood. So what are they? They basically, again, these are coverage policies that require a patient to try something less expensive and fail on that treatment before receiving any coverage at all for another more expensive option. And why do we even have step therapies? Well, from an ethical perspective, they certainly are consistent with insurers' larger goal and responsibility to exercise prudent stewardship over limited healthcare resources. They, in some ways, are certainly less restrictive than a full non-coverage decision on a drug, because you can get to it if you go through a hoop, if you will. And it's certainly possible, although this is up for part of the debate, whether they are consistent with the best application of the evidence on the relative effectiveness of different treatment options. So we were struck by the fact that even though the use of step therapy policies are growing rapidly, so for instance, in the most recent survey, upwards of 67% of commercial employers in their benefit design are now including step therapy policies. This is up from around 25% 8 years ago. And they are used quite often, as you might expect, for expensive drugs, including specialty pharmaceuticals. And there has been a lot of controversy over them, but in a kind of a patchwork fashion. In different states, there are very different legislative rules right now that limit step therapy policies in different ways. The length of time they can extend, the types of conditions they can cover, etc. And it's different at the Medicare level as well. With all this patchwork, though, there really hasn't been, to our knowledge, a good kind of attempt to try to frame the larger ethical criteria by which we might consider step therapy policies to be reasonable. So that's what we set out to try to do. Now, this is the full set of criteria that we call design criteria because they should be used, we think, when a health plan or a public insurer sets out to design a step therapy policy. Now, many of these will sound like motherhood and apple pie. Most ethical criteria end up starting, or at least start out sounding that way. But if you dig a little bit deeper, I think there are some useful nuggets in here. So, for instance, the very first one, weigh short-term cost savings against long-term clinical and economic outcomes. This is to make the point that it's possible for insurers to focus just on the short-term costs. And if a drug produces long-term value by perhaps reducing the need for doctor's visits or hospitalizations, or obviously improving patient outcomes over the long term, that needs to be the full scope with which they look at both the clinical and the economic outcomes when deciding whether it makes sense to try to use step therapy policy to reduce the costs in the short term. The second one says ensure that first step drugs are clinically appropriate for nearly all patients. So if you're going to require patients to try drug A before they can get drug B, drug A really should be clinically appropriate for the vast majority of patients. Well, how do insurers know this? What we say in the paper is that it's very important that insurers work with clinical experts and patients. In today's world, we think that it's really necessary that insurers reach out to patients to understand if there are clinical scenarios and patient-specific scenarios that make drug A not a reasonable first choice. That really has to inform the whole process going forward in order for any kind of step therapy policy to be considered fully ethical. Just briefly, giving patients an excellent chance to meet clinical goals suggests that even if, failing on drug A isn't going to kill you, you should have a pretty good chance of achieving your clinical goals. If you only have a 1 in 4 chance of achieving your clinical goal with drug A before you get to drug B, that's not a good example of a place in which step therapy makes sense. And first step failure should not cause long-term harm. Again, how to decide explicitly when a harm is irretrievable, when it's significant, and how much of a risk we are willing to put patients at when they have to try drug A before getting to drug B needs to be very clearly defined, explicitly and transparently. I'm going to skip the rest of these in the interest of time, but we can come back and they're each described in the paper. We recognize that just laying out these design criteria probably wasn't enough to really help fully, so we also decided that we should describe the specific evidence scenarios that would make step therapy a reasonable approach. And again, I'm just going to focus on a couple of these to indicate that basically we can start with a certain kind of population level evidence. That means evidence on large groups of patients, usually from large clinical trials. We also have this idea of whether the heterogeneity of treatment effect varies a lot. That means, do patients really usually all react the same to a certain drug, or is there a huge bell curve in which some patients will react very well and others not at all? And then what's the ethical burden on payers? So for instance, if drug A and B have equivalent safety and effectiveness, and their heterogeneity is limited, that means that virtually all patients respond the same to each drug, then the ethical burden on payers related to a step therapy policy is quite low. On the other hand, again, at the population level, drugs A and B might have equivalent safety and effectiveness, but we know that there's really a lot of variation in the way that patients respond. That creates a greater burden on the payer to justify a step therapy and to be very careful about all the different design criteria to make sure that they support it well. And then down here, when you could actually consider doing step therapy, if drug B is safer or more effective, or both than drug A, But that creates a very high ethical burden for payers. You're really telling patients and doctors you have to use a less effective drug first. It might still have a good chance of working for you, but we're going to hold off on the more effective drug until you try drug A first. That just heightens the ethical bar on all the different design criteria. Very briefly, the policy applications we felt is that this should provide a more explicit internal guidance system for payers as they think through explicitly the steps towards a potential step therapy. We hope that it might provide a benchmark for accreditation bodies when they look at payer policies and perhaps ACOs that will be adopting step therapies. And now, given the patchwork approach, we hope that this can serve as a framework through which states and other entities that might want to consider legislative action to, in a sense, define the appropriate boundaries for step therapy policies. Hopefully this can give people a template from which to work. Thank you very much.
All right, well, thanks. I want to thank Health Affairs for inviting me to share the results of our analysis with you. My name is Aaron Kesselheim. I run a group called the Program on Regulation, Therapeutics, and Law at Brigham and Women's Hospital and Harvard Medical School. And I want to talk about aspects of the FDA's gatekeeping function that are particularly important to specialty drugs, given their key role in patient care, association with serious risks, and very high costs. So one of the FDA's central responsibilities is to balance the efficient review and approval of drugs with the potential to improve care, with the need to protect patients from widespread overuse of products that have substantial safety risks in on- and off-label contexts. For anyone who might not know, an off-label use of a drug is a prescribing of a purpose not officially validated by the FDA. Our earlier review of 4 specialty drugs found rapid post-approval increases in off-label use that cost $500 million for state Medicaid programs alone. And though certain off-label uses are evidence-based and clinically reasonable, off-label use of these products are common in non-evidence-based contexts that presents patients with risk of substantial harm. So the FDA's regulation of specialty drugs must expedite access to life-saving drugs on the one hand and limiting overuse on the other hand. The first way the FDA can help expedite availability of particularly promising specialty drug is through an expanded access program that allows physicians to prescribe a drug before formal regulatory approval for patients with pressing clinical need. To date, the FDA has taken a very permissive posture towards expanded access programs. For example, 99.9% of the nearly 2,500 single patient requests received by the FDA between 2010 and 2013 for expanded access were allowed to proceed. The FDA also recently permitted companies to charge direct costs of supporting a compassionate access program. However, expanded access remains underused. Manufacturers cite a number of important logistical problems, including limited supplies of investigational drugs and the potential that adverse outcomes experienced during an expanded access treatment will negatively affect the FDA's review of the formal application. Specialty drugs are difficult and costly to produce, are likely to register reportable adverse effects during the expanded access program that manufacturers believe could reduce their chances of approval, and are likely to command exceptionally high retail rates, making companies less desirous to charge the direct costs during the investigational process, or else face potential bad publicity when the price skyrockets after approval. However, expanded access is nonetheless important. For example, one time when expanded access is particularly essential is when the efficacy of the drug has been established, but formal FDA validation has not yet been granted. The FDA should therefore ensure that manufacturers' plan for this periods are formalized when the manufacturer initiates human clinical trials originally. Fortunately, in the modern era, this period of time is usually no more than 6 months and often less. In addition, some have suggested that the FDA be excluded from considering data from expanded access patients, but this I think is a bad solution and would prevent the FDA from deriving helpful lessons from these experiences. Rather, to remove the hurdles of unfounded fears over expanded access adverse events, the FDA could work closely with manufacturers to make clear how expanded access data are reviewed differently from usual clinical trial data. As a complement to expanded access, the FDA can use its existing expedited approval pathways to accelerate the development time of potentially transformative specialty drugs. The Fast Track program allows approval of drugs treating life-threatening or severely debilitating conditions on the basis of phase 2 trials alone. Accelerated approval allows approval of life-saving drugs on the basis of surrogate endpoints rather than real clinical endpoints. Priority review accelerates the basic review time the FDA gets from 10 to 6 months. And most recently, the FDA got the capacity to designate certain drugs as breakthrough therapies based on early clinical signs of promise, including an effect on a pharmacodynamic biomarker that wouldn't even meet criteria for an acceptable surrogate endpoint in other circumstances. From 2010 to 2013, 61% of fast-track drugs were specialty drugs, 70% of accelerated approval drugs were specialty drugs. Of course, since so many specialty drugs are approved on a shortened pre-market trial period, expedited approval must be accompanied by timely conduct of confirmatory post-approval trials. However, the FDA has historically had limited power to ensure that these mandatory post-approval trials are conducted in a timely fashion and in a rigorous manner. One reform option would be, therefore, to set explicit deadlines by which time manufacturers' trials must be conducted, formally sunsetting approval of the drug, which would remove the institutional barrier of requiring affirmative FDA action, or by imposing meaningful penalties for failure to meet these requirements. There should also be more widespread communication to the physician and patient communities from the FDA about the limited evidence supporting the approval of specialty drugs on these expedited pathways. While taking steps to ensure access to promising specialty drugs, the FDA can also help ensure that specialty drugs are directed to the patients most likely to benefit from them. One of the most powerful ways they can do this is by influencing the scope of the approved indication. If the indication is too broad, it can invite inappropriate use, even when that use is seemingly consistent with the label. For example, the drug Epogen was approved to treat anemia, but the goal red blood cell level in the clinical trials was not explicitly identified in the approved indication, and as a result, in the years after approval, and based on manufacturer promotion, on and off-label uses of that drug grew quite high. And and raising people's hematocrit levels to higher levels that was found to be associated with increased patient mortality without corresponding benefit. A related way that the FDA can prevent overuse is by approving the drug with a companion diagnostic test. The FDA has encouraged manufacturers to link investigational drugs with companion diagnostics, and there have been a few notable recent successes. But to date, the FDA lists only 13 drugs that have approved with companion diagnostics in the past 2 decades. 12 of them, I might note, are specialty drugs. The FDA can also attempt to prevent inappropriate overuse of specialty drugs by requiring a risk evaluation and mitigation strategy. The REMS pathway was created in 2007 and can include elements to assure safe use, strategies that the manufacturer must implement to ensure that only the patients who meet the requirements of the REMS are able to obtain the drug. REMS have been widely used, and about half the REMS that we surveyed relate to specialty drugs. And REMS have been shown that they can reduce off-label use of drugs. However, the FDA can currently only require a REMS if there's a serious known safety risk. So for REMS to be useful in helping direct approved specialty drugs to the patients known to benefit from them, the FDA will need congressional authorization to expand the scope of the program. Finally, though the FDA by law cannot take cost into account when reviewing its applications, it can take steps that indirectly affect unnecessary spending on specialty drugs. Obviously, decisions such as how to word the scope of the approved label or whether to impose a REMS can strongly affect how much patients and payers spend on specialty drugs. In this vein, the FDA's strongest impact can come when it withdraws an indication from a drug, which can occur as in the case of Avastin for metastatic breast cancer, after post-approval studies, when they're conducted, of drugs on an expedited pathway show lack of effect. Another way that the FDA can indirectly control spending on specialty drugs is by facilitating market competition. The most effective such competition, as Rena mentioned earlier, comes with introduction of generic drugs at the end of the patent-protected exclusivity periods. But many specialty drugs are biologic agents for which generic versions are not yet available. In 2009, Congress created a framework for the FDA to review and approve equivalent versions of biologic drugs. Follow-on biologics can reduce prices by 25 to 30%, but require heightened regulatory attention because proving equivalence can be complicated and there is risk of undesired immunogenic responses. The FDA, however, has been slow in turning this framework into a viable pathway for follow-on biologics, which are now being widely used in Europe and other countries. To help rein in spending on certain classes of specialty drugs, the FDA must work to create a viable market for the sale of safe follow-on biologics. So, in conclusion, because of their unique cluster of characteristics, specialty drugs deserve a more proactive regulatory posture than other new drugs during development and FDA review. Our review highlighted a number of tools that the FDA has at its disposal to facilitate efficient approval of potentially transformative specialty drugs and access to those products for desperate patients, as well as to ensure appropriately controlled use of the specialty drugs after approval. While dramatic new approaches are not likely to be necessary, more thoughtful and effective implementation of existing mechanisms could enable sophisticated regulation of these sophisticated new products. Thank you.
Good morning. My name is Pat Gleason, and I work for Prime Therapeutics, a pharmacy benefit manager owned by 13 Blues plans, providing pharmacy benefits to 25 million Americans. I'd like to thank Health Affairs for the opportunity to speak about our research we've done looking into coupons and their association with adherence. So before I begin, I'd like to share with you and briefly discuss pharmaceutical manufacturer financial assistance programs. There are really two types. They're for the programs for the indigent or the needy, for which pharmaceutical manufacturers or the foundations that they fund provide substantial or complete free drug, complete cost avoidance to the member or the individual. These costs are avoided through submission of income information and are dependent upon then showing that you have a low income. Coupons, on the other hand, do not require submission of income information. They're directly provided from the pharmaceutical manufacturer to the patient at the point of sale at the pharmacy. Coupons are, for the most part, have a maximum amount of the true cost avoidance of about 20%, where the insurer is picking up the rest of the tab. So it's important to understand the differential between the different financial assistance programs that are offered by pharmaceutical manufacturers. Within coupons, there are really two types of coupons. There are coupons for which branded products have a substantially less expensive generic or therapeutic alternative available. Those coupons add cost to the system and should be discouraged. And then there are coupons for which there isn't a less expensive alternative available. These branded products are primarily specialty drugs. And it's these specialty drug coupons for which we have very little information about their prevalence of use, the savings to the member, as well as the potential association that they may have with improving adherence. And that's what our research was done to try to find answers to those questions. So to begin with, Prime Therapeutics has a specialty pharmacy for which we dispensed in 2013 over 265,000 specialty prescriptions for individuals who are privately insured. So all these individuals have private insurance. They're not Medicare Part D. They're privately insured individuals. We dispensed 250,000 prescriptions at a true cost of $911 million. $35 million was asked to be paid by the member or the co-insurance. That's 3.8%. That's less than 4%. Of that $35 million, 117,000 prescriptions had a copay coupon assistance provided. That's 44% of the 265,000 prescriptions. 21 million of the 35 million in cost share that was asked to be paid was covered through coupons. That's 6 of every $10. And as you can see, what happens when a coupon is applied, pre and post, the cost share. So on the far left is a cost share of $50. Before coupon, 57% of the 117,000 prescriptions, the member was asked to pay more than $50. After coupons, 3%. Another number is $250. You can see 12% of individuals are asked to pay more than $250 for their prescription before the coupon, 1% after. In a separate analysis now, we're not looking at coupons in this analysis. We're simply looking at individuals who are beginning new therapy for multiple sclerosis or biologic anti-inflammatory drugs. So they're newly initiating this therapy, and then we bucketed them into the cost share they were exposed to at the point of time they went to go pick up that new prescription. And you can see in the far left, the group that had a cost share of less than $50, about 1 in 16 abandoned therapy. They went to the pharmacy, they dropped off the prescription, they didn't pick it up. They abandoned that therapy. As the cost share moves into the middle range of $250 to $500, 1 in 8 of the multiple sclerosis patients who are filling a multiple sclerosis prescription abandoned therapy, 1 in 13 of the biologic anti-inflammatory agents. Now, it's important to point out at this point that the average cost today, true cost, for a biologic anti-inflammatory agent, that would be Enbrel, Humira, many of those prescriptions, is over $3,000 a month. And multiple sclerosis drugs, over $4,000 a month. As we move to cost shares of over $500, you can see a dramatic increase in the abandonment rate, becoming statistically significant. And as cost shares become half the cost of a drug for MS, that's over $2,000, every other patient or more is abandoning therapy. There are many tools to manage specialty pharmacy. Cost shares are just one of them. And as you can see, but they're important. They're running along the top of this figure because many of the tools below that, utilization management and contracting activities, for example, are dependent upon developing a formulary and having cost share differentials between the preferred tier drugs and the non-preferred tier drugs. So in conclusion, as patient cost shares go beyond $250, we found an association with higher abandonment rates. We at Prime Therapeutics believe that a cost share for a preferred formulary specialty drug tier should be $250 or less in order to avoid this abandonment. When coupons were applied, they substantially reduced patient cost shares. 99% of the time, someone was exposed to less than $250 cost share once coupons were applied. Part of the negative ramifications of coupons are that when they are used for non-preferred products, they are likely to increase costs to the system. So as coupons are used in non-preferred products, especially when those non-preferred products haven't been first approved through a prior authorization or step therapy program, they're likely to add costs to the system, increasing risk for premiums. And lastly, as policymakers make decisions about putting caps on cost share tiers, it's important that they understand the potential ramification on costs as well as on potential limits to access that those policies will make. Thank you.
Hello again. Today, I'm going to talk to you about some work that I have done with my co-author, Peter Bach, on how expansions of 340B eligible hospitals appear to be eroding the core intention of the program to serve the poor and uninsured Americans. What is 340B? 340B is a very little known discount program. It's for drugs. It is named after Section 340B of the Veteran Health Care Act of 1992. That act also established the federal program for Medicaid drug rebates. Under the statute, eligible entities may access discounted drugs for the care of their poor and indigent patients. And those discounts can be quite substantial, on the order of magnitude similar to that of offered through the Medicaid rebate program. Manufacturers who participate in the Medicaid rebate program are required by statute to offer those same drugs to eligible providers for eligible patients. As I mentioned, the program started in 1992, and it was actually at that time quite small. However, the program has expanded in several ways over the past several decades. Notably, approximately 1/3 of all non-federal hospitals now qualify for this program, and clinics that are eligible for the program simply by virtue of being affiliated with 340B eligible hospitals have exploded in number. With this expansion has come increasing scrutiny by a variety of independent investigators. Perhaps most notably, there has been scrutiny on hospitals. Hospitals that qualify for the program by virtue of the disproportionate share program. And I believe that there are two reasons why. First, these hospitals qualify based on the poverty of their inpatient census. But remember, this is a program that provides access to drugs in the outpatient setting. Secondly, this is a program that these entities are not required by statute to pass on these discounts to either the patients that are served by these discounted drugs, nor to their insurers. This gap between the discounted drug at the acquisition phase and the reimbursement phase, which does not need that, where that drug price does not need to be passed off, creates a spread or profit. These institutions can generate very significant revenues based on this program. According to a Senate Finance Committee letter dated from last year, for selected hospitals, the revenue generated from the program can amount to approximately tens to millions of dollars over a 5-year period. We believe that there are several potential unintended consequences of the way in which the statute is currently written. In a series of work that Peter Bach and I and others have embarked upon, we have investigated systematically these unintended consequences. One of the unintended consequences is related to merger, affiliation, and related activities between clinics and hospitals. The availability to profit off of this program may sweeten the pot, if you will, between hospitals considering merging or opening clinics in certain locations. Oops, sorry, I have to go back. This is a hypothesis-driven study where we empirically investigate whether the communities served by the clinics that have expanded over recent years are serving patient populations that are poor and uninsured as the program originally intended, or whether the program is expanding in ways that could potentially generate profits for the institutions and therefore erode core program goals. The data we use is nationally representative. It comes from the government organization that oversees the 340B program. It includes all hospitals that qualify for the program based on their disproportionate share percentage, matched to their 340B eligible clinics that also register for the program. In 2012, we matched those institutions to the socioeconomic characteristics of the communities served using the U.S. Census Bureau data. The data we use discriminates between clinics that affiliated with the program in 2004 forward versus 2003 and in previous years. And the measures we use to evaluate the program are listed on the horizontal axis. The vertical axis displays the difference between the communities served by the clinics relative to the hospitals. And we discriminate between these institutions based on the timing of their 340B qualification using the date of the original institution qualifying for the program based on the HRSA website. To be more specific, clinics that affiliate with 340B institutions and qualify for the discounts, among those who qualified for the program previous to 2004, are serving a very significantly unemployed population. In contrast, those clinics that affiliated in years after 2004 are serving a dramatically less likely population to be unemployed. These results are consistent for our uninsurance measure. The The outcomes for poverty, but also for mean and median outcome, require a little bit more explanation, but are consistent in direction to these other measures. Let me explain. In all years, the affiliated clinics are serving a slightly less poor or slightly more affluent patient population. However, in the clinics that qualify for the program after 2004, they are serving a much more dramatically wealthier patient population. We have tortured this data to provide absolute assurance that what we are finding is not an artifact of time passage, of community drift in the socioeconomic characteristics of this community, nor is it an artifact of these measures and their parameterization alone. Every single way we have run this data shows results that are consistent to this, and every single difference that we have found has been statistically significant at the traditional thresholds. Therefore, we believe that we are providing the first independent empirical evidence that the program is expanding in ways that clearly erode the original intent to help the poor and uninsured. Thank you.
I could ask a lot of questions, but I have a funny feeling there might be a few in the audience. So let me start and see how much we can get in. I'm willing to run a touch into the break, but I see two folks on the aisle. And please, again, introduce yourself. Questions, please.
Hi, I'm Maureen Testoni. I'm with Safety Net Hospitals for Pharmaceutical Access. And my questions are to Rena Conti. And I have so many, I'm not sure exactly where to start. Let me make 3 comments, and maybe you could comment on those.
Okay.
So,
how about one comment or a question? That's
well,
really...
they're all related. So, you say that that your study is showing that the program is changing, and that 340B hospitals are not providing the care to vulnerable populations that was intended. But I don't recall anything in your presentation where you compare 340B hospitals to non-340B hospitals, and I know in your article you talk about the fact that there is a long-standing trend, well-documented trend of hospitals acquiring and doing more physician affiliations. So without any kind of comparison between 340B and non-340B, I'm not really sure, I don't really see how your data can make the argument that there's any kind of a shift in where the care is being provided. Apart from which,
that's a great question.
But there's one more thing.
I think that's a great question, and
Thank you. I'm going to try to answer the questions that I heard. First, our data does not. We were not examining whether or not the program is serving poor or uninsured patients. What we are doing is examining whether, on a national level, whether these clinic affiliations are expanding into populations that are not poor and uninsured. And therefore, these institutions can generate profit off buying these drugs at low discounts and selling them at prices that are much higher.
But there was no evidence that that's actually occurring, and no evidence, like you didn't look at the patients that were treated at these clinics or anything like that. But the other thing I wanted to say...
Okay, I'm going to cut you off because I've asked a few times for you to stop, and now there are other people who'd like to have a chance to ask some questions. Thank you. Go ahead.
She actually asked one.
She asked your question. Great.
This question is also for Dr. Conti. I'm Christopher Vaz from the American Hospital Association. You've looked at actually zip code. You talk about the communities that hospitals are serving, that you'll look specifically at the communities being served by hospitals, but really looking at a zip code tabulation area, which is a very small area, is not really the communities that our hospitals are serving. And we do understand that you talked about looking at PCSAs as alternative areas. I think, and you talked about HRRs, hospital referral regions, not being very not being a good unit of analysis, but even if you don't think that that's a good unit, what about health service areas where hospitals are getting a majority of their hospitalizations from? So just trying to figure out how such a small unit of analysis can be a meaningful way of talking about the communities being served by our hospitals.
That's a terrific question. Thank you. Hospital service areas are not an appropriate unit of analysis, and that's because it's related to the inpatient census of the hospitals, as you just mentioned. This is an outpatient program. So therefore, the unit of analysis has to reflect the population served in the outpatient setting. Our analysis used a variety of different ways in order to capture the community. One was zip code level, or what the U.S. Census Bureau considers to be a zip code. Secondly, at the primary care service unit, which is what the Dartmouth Atlas Group uses to characterize patterns of care across communities in the nation. And finally, we did investigate using hospital referral regions, but again, we didn't think that that was the appropriate unit of analysis here. Thank you.
We have a lot of interesting papers up here. I encourage questions on all of them, although obviously if one of them is of the greatest interest, I won't dissuade you.
Thanks. I hate to ask two questions in one day, but it's for Mr. Gleason. I neither take prescriptions nor prescribe them. I'm not a doctor, so I'm kind of it's a procedural question about your research. How do you know a coupon is used?
Yeah, that's a very good question. And also one of the reasons that there isn't much research in this area. Being the specialty pharmacy dispenser and the pharmacy benefit manager owning that pharmacy, we paired up those prescription records and we keep track, and we actually have an active group of individuals at our specialty pharmacy that optimizes coupons for individuals who are filling those specialty drugs, in particular to focus on first the preferred products, and then if someone fails via step therapy or prior authorization, we'll apply a coupon to the non-preferred products. And the record keeping is very strong. We then tied, with de-identified data, those records to the insurer side of the business to see what the actual insurer said they were asking an individual to pay based on the adjudication of the prescription and the parsing of the amount that the insurer covers and the patient is asked to pay through their insurance. We combined that information. So that's how we got to the numbers we obtained.
I want to ask a question of Steve real quick. You presented a framework. You also mentioned that there are state laws and insurance practices around step therapy. I wonder if you could tell us anything about the transparency of those that are already in existence. I mean, you set out some criteria. If I'm in a covered plan, do I know, is it easy for me to find out what the answers are and how those step therapy choices are made?
Well, good question. It's obviously risky to generalize because it's hard to do a systematic study of how transparent these policies are. I do know, though, from talking to a lot of PBMs and insurers that in general, when potential enrollees are looking to sign up for a health plan, it's extremely difficult for them to access the pharmacy information at a level that would help them understand which drugs are put under step therapy policies. Once you're in the plan, then you can kind of drill down and sort it out. But even then, it's tricky for people who don't know what they're looking for. So I do think that transparency is one of the things that many insurers and PBMs recognize are still a challenge.
Thanks. There's a question here in the middle.
Hi, Mariella Payne with Ascension Health. This is to Dr. Conti. You suggested that there's a spread or a profit. Did you look at what those profits or that spread was used in specifically? So you suggested there's money there, but you didn't really, other than through inference, suggest how that money was being spent. And one thing I would point out that many of the more affluent communities include middle class, people who have inadequate insurance coverage and cost sharing. So they often can't provide some of the drugs like your earlier remark said because of the price increases. So I guess my question is, what is that spread used for? Do you have did your study look at that?
My study did not measure the magnitude nor how this profit is being used by these institutions. However, by statute, neither do the hospitals don't have to report that data to HRSA either.
Have you done any case studies to suggest how that money is being used?
Yes, I have.
If we didn't publish it, we're not interested in it. No, if there's additional information you want to share, please do so. Okay. Any other, please?
This is all from Dr. Conti.
In your article, so easy in the earlier panel.
I noted in your article you said that recent analysis, other analysis, suggests that hospitals are shifting specialty care from inpatient to the outpatient setting, possibly also to generate benefit from the 340B program. Did your analysis get into that to confirm or refute that finding?
Yeah, thank you very much for the question. This is very important. There are at least several ways in which this program can create unintended consequences. One of them is related to expansions of the program into wealthier and wealthier communities where there's an opportunity for profit. Another one is shifts in the site of care. There's clear documentation by IMS Health and other reports suggesting that oncology care is shifting into community practice or into outpatient specialty units that are related to the hospital. This is true for other specialty care practices as well. There is clearly an opportunity to profit off of that type of behavior as well.
We're going to take one last question here and then keep us not too late into our break.
Martha Talley from the Office of Inspector General at HHS with another question for Dr. Conti. I just want to clarify something. It had been my personal understanding, and this is a question from me personally and not my office, that there is a tremendous increase in, or an increase, shall we say, in hospitals acquiring physician practices. But I was aware of a number of factors influencing that, including the fact that hospital-based services are paid at a higher rate than physician-based services. And in the oncology field, in particular, since you just mentioned that, a recent change, a relatively recent change in the payment practices with regard to outpatient oncology drugs administered in physician practices versus hospital-based administration has caused some of that shift. I assume you didn't mean to imply, but I'm interested in whether you did, that the 340B program itself is driving the acquisition of physician practices.
Yeah, thank you so much. That's an incredibly important question. Just to be clear, the site of care changes that we are seeing aren't actually increasing the payment rate. Instead, what they're doing is they're allowing these institutions to charge a facility fee in addition to the care that's being provided. Okay, secondly, the world has changed since 1992. This program, at the time of its inception, hospitals were very, very different beasts. They mostly served patients in the inpatient setting. Things have changed. Things have changed for a lot of reasons. Clearly, care is being pushed. Specialty care is wrapping around hospitals, but also these hospitals are pursuing affiliations and, frankly, opening other hospitals or gobbling up hospitals in much more geographically disparate communities than where they originally served. This program, as it's originally written in the statute, suggests that these hospitals qualify for the program based on the poverty of their inpatient census. That no longer reflects how hospitals behave. What I am suggesting is that there are many reasons why these hospitals are pursuing this type of expansions. Many of these reasons are related to the Affordable Care Act and its changes. However, the availability of 340B profits sweetens the pot for certain selected types of expansions. Thank you.
So as we go into a break, I just want to assure all of you who are listening that we at Health Affairs are interested in a robust public policy debate. In fact, we're enthusiastic that we're able to contribute material to promote that debate. I also, though, want everyone to understand that the primary goal when we have a release event, as we have a new issue that just came out, is to assure that authors who've gone through a peer review process prior to publication have the opportunity to present their findings and that you have an opportunity to ask questions and clarify, knowing that there will be many opportunities, some of which we will sponsor and others which, of course, others around town will sponsor, to engage into the more heated debates over the appropriate policy. But our goal really is to introduce brand new material that has gone through peer review and to give you an opportunity to ask questions, and that's why we structure the day as we have. We'll take we're running a little behind, but I think we can still afford a 12-minute break or so. Please join me in thanking our panelists. I've strategically located myself in the middle, though I have a funny feeling this won't be quite as fiery as the earlier conversation, though maybe it will. If you all could come in and take your seats, I'd like to get us started. I'm pleased to be able to have a discussion today. On my left, your right, is Troyen Brennan, the Executive Vice President, Chief Medical Officer of CVS Health. He's been the CMO of Aetna and was the President and CEO of Brigham and Women's Physicians Organization, has been a professor of medicine at Harvard Medical School and a professor of law and public health at the Harvard School of Public Health. Pleasure to have you here. On my right to your left is Peter Bach, the Director of Memorial Sloan Kettering Center for Health Policy and Outcomes, a faculty member in the Department of Epidemiology and Biostatistics since 1998. He's been a senior advisor for cancer policy to CMS here in DC, a member of the Institute of Medicine's Board on Healthcare Services, where I serve as well, and I've gotten to know Peter there, and chair of the Center for Medicare and Medicaid Services Technical Expert Panel. So we have two people very knowledgeable about the field, and I thought we would try to have a little bit more of a conversation. Troy, you have a paper in this issue, and so I'd like you to present some of what's in that paper. But I realize as I listened to some of the questions, I probably made a little mistake at the outset in not offering, although there's no single definition of specialty pharmaceuticals, but maybe we should, in some sense, start at the beginning because you, in your paper, look at growth in this area. So what's the topic we're talking about when we talk about specialty pharmacy? And just to begin by thinking about what's in your paper, why is it that we're seeing spending in this area increasing? Some of the topics have already been raised, but there are others. You give a fairly thorough explanation of the growing role. So why don't you kick us off?
Well, I think that you asked about it in the previous conversation, a little bit difficult to define. The traditional definition would have been difficult to handle, often injected, and very expensive. But sort of looking at our spend over the course of the pharmacy benefit management part of our company, Caremark, over the course of the last 6 months, the big players there are obviously the hepatitis C drugs, but then Tecfidera comes up. Tecfidera, if you talked about it 15 or 20 years ago, it was basically it's dimethyl fumarate. You could buy a railroad car full of it. It was produced largely in China, and they used it to defumigate shoes and sofas and things like that. Actually, it was found to be irritant because it was put into sofas, and people in Finland were getting rashes from the sofas, and so they stopped exporting it to the European Union. But now you know it as Tecfidera. which is a drug that's used to treat multiple sclerosis, and it's an oral medication. It's very expensive now, as Tecfidera, and so it fits the definition of expensive. But when you think about it in terms of difficulty of handle or especially difficult to make or injected, it doesn't fit any of those things. So increasingly, we're defining specialty medications as medications that tend to be expensive.
Well, it certainly simplifies things. You don't need an MD to figure that one out. So in the paper, you do discuss the growing spending in this area, and obviously if they're expensive, that's got to be one contributing factor to spending more money, but there are others as well. They're not all available in trucks and railroad cars. So can you expand a little bit on the growing role they're playing?
Well, as we look at it, we're heading to about 2 to 3% of the medications that'll be prescribed will be specialty medications by 2018 or 2020, but it'll be about 50 to 55% of the total drug spend. So, we're seeing more and more medications sort of coming through as specialty medications, especially the biologics, things that are obviously much more difficult to develop and manufacture, and often things that are not going to fall into this typical approach towards manufactured generic medications. So have longer intellectual property protection, the whole biosimilar area. So we're just expecting to see sort of continued growth, and there's also some biology, which Peter could talk about, that's exciting and pushing us in the direction of development of these kinds of medications. But you still come around to the cost issue, no matter how you look at it.
So in your paper, you talk about what you term both traditional and novel management approaches. Give us a sense of what those approaches are, both traditional and novel, to address the growing spending in this area.
Well, traditional would be either a prior authorization in order to make sure that the patient needs to be taking this medication, and that there aren't other alternatives that would be less expensive. We call that sort of minding the bad trend. That is, making sure patients are only taking medications that are necessary, and making sure they're not taking unnecessarily expensive medications. So prior authorization would be one way. Steve Pearson talked about step therapy. We would use step therapy to try people on lower cost approaches before you go to a higher cost approach. And these are issues that are all overseen by our independent Pharmacy and Therapeutics Committee, and at least for Medicare, all those criteria are basically sort of published on healthcare.gov and have to be approved by Medicare, to whom we submit them at the time we submit the formulary. I'd say a different approach, or a newer approach, is to use a formulary approach. And that's to basically say medications, this medication is the one that's on the formulary, much more difficult to get a formulary exception. So, if you take the case of say, Tecfidera, for example, which is somewhere between $55,000 and $60,000 a year for treating multiple sclerosis, and is growing because it's an oral medication. The whole couponing discussion that we just heard would basically make it difficult to sort of use a prior authorization or a copay structure in order to get the patient to move to a less expensive medication, whereas formulary would work even in that circumstance. But you can understand that the average out-of-pocket payment, well, the out-of-pocket max for most of commercial insurance today is $6,400 under the PPACA, and in Medicare it turns out to be a Medicare Advantage plan about $4,700. So one dose of Tecfidera, you get a coupon for that, a monthly dose for a month of it. That's basically going to cover your entire copay. So you essentially would be able to get the medication for free after one coupon. So if that's the case, that's obviously what the pharmaceutical manufacturers are doing to get around economic-based incentives to move patients to specific medications. A formulary approach will overcome that.
This is a thorny topic where we start sort of with the economics, but we also need to talk about the health and quality implications. I'm going to follow on the money side for a few minutes before we turn to the other. Peter, let me bring you into the conversation. Timing is good. Many of us saw you on 60 Minutes just 2 days ago, and part of what you were doing was criticizing how drugs are priced. Can you, for those who didn't see the segment or in maybe a somewhat less edited environment, can you give us a sense of how specialty drug pricing works and what the source of your criticism is?
Well, sure, and thanks for having me, and it is propitious timing. This 60-minute story just retold what we did a couple years ago where Sloan Kettering, one of the nation's largest cancer hospitals, rejected Sanofi's drug Zaltrap from its formulary based purely on its price. And the argument was that it was about twice the cost of Avastin in the same indication, second-line metastatic colon, and that the coinsurance for Medicare patients, and those are the predominant patients that we serve with colon cancer, is about 20%, and so the difference was about $2,000, slightly over $2,000 a month out of pocket for Medicare patients where there's no upper limit for people who are naked on their coinsurance, compared to about $1,000 for Avastin. We rejected it for that reason, pointing out that although people don't tend to think about the limited means of the elderly, $2,000 a month, or in this case it was $2,100 a month, perfectly matched the median adjusted gross income of a Medicare beneficiary. So that's it, all of their money, no food, no electricity, anything, just Zaltrap. So we rejected it, and then kind of an alarming thing happened, which was that Sanofi read the New York Times that day and lowered their price. And they did it in a way where they didn't actually lower their price. They instituted a rebate program so that docs could purchase it for full price, and then they would get a rebate of 50%. But then when they passed on, much like the 340B program, when they passed on the bill to...
I was hoping you wouldn't bring that up.
I'm sorry. That's an impossibility. It's going to be in every sentence. But then they passed on the bill to the insurer, it was as if they had purchased it at the real price, right? And Medicare made no correction to that. And the 60 Minutes piece focused on this sort of system structure that required Medicare and private insurers to pay whatever the price was pegged at. And then also this sort of weird thing where when Sanofi lowered their price using a rebate mechanism, it didn't pass through for a couple of quarters. So that created big profit incentives for docs. And private insurers, some of them, including Aetna, actually tried to claw back this rebate. I don't know how successful they were.
So this is, you're describing Medicare pricing policies. You're working with commercial carriers, and obviously some of the drugs we're talking about, as you note, are predominantly for the elderly. Are these kinds of distortions or games possible in the commercial world that you all are operating in? Or how do the dynamics play out in your world relative to what Peter described?
Dynamics is how I describe it rather than games, but definitely it does. And when I was speaking of, both from Medicare Advantage, traditional Medicare, and PDP, we have a hand in all those things. So I would say, it plays out on both Medicare, Medicaid side, and in commercial insurance. So obviously the most arcane area is when it's basically being adjudicated as a Part B element. That means that the doctors are basically buying it and then selling it back to the insurance companies, which is the way that most of the oncology drugs are done today, especially those that are injected. And there it gets very complicated in a hurry. And I think that the pharmaceutical manufacturers think that there's not a lot of price sensitivity for the individual consumer there, and hence that's why we're seeing really broad inflation in new products that are coming out.
Now, you describe this Medicare as a price taker, but as an earlier paper presented today, you can't use coupons on the Medicare side, but you can use it on the private side. So maybe the games is the wrong term, but it seems like we have a lot of different markets with very different rules, and no criticism intended, but those who participate in those markets are trying to figure out how to optimize their ability to function in each of those markets. That sounds kind of normal to me. What's the problem?
Well, it's America, so we'll get to a new solution later. But it's true in the Medicare and Medicaid programs, you can't use compound-specific or drug-specific couponing, but you can go through foundations which are set up to target, for example, diseases, groups like lung cancer or cancer or something like that. There's been some pushback, particularly from the feds, in terms of how narrowly defined those foundations can be. But nevertheless, there are mechanisms, but it's not widespread in terms of the Medicare program. Sitting in econ class, everyone recognizes coupons are artificial price supports, because what they do is they pull up those people who can't cross the threshold of affordability so that the average price does not need to fall. Sitting in an office with a patient in front of you, you see them as a net good for that patient. So this is a really complicated tension. And as Troy just pointed out, that they eat through the deductible, even though it's not money from the patient's pocket, is either wonderful for patients or corrupting to the financial structure. It's difficult to sort of come down either happy or sad about them.
Are you either happy or sad about them?
Well, I think it's important for the healthcare system overall to be concerned about costs, and obviously these are costs that look not sustainable over time, and so yeah, I think it's important to be able to sort of take advantage of whatever programs you can that are going to basically drive patients to the right medications. We talked about the biologics that are used in rheumatoid arthritis, for example. There's been a couple of great papers, including a recent randomized controlled trial in the New England Journal of Medicine suggesting that triple drug generic was just as good, and people adhered to it even better than they did to biologics. So you could think about sort of packaging up triple drug therapy and giving that to people, and you'd have tremendous savings associated with that. But if you can't create financial incentives for individuals to sort of use that, then and the couponing takes that away, then it means that we've got a perfectly good approach, which we should be using as a cost-effective healthcare system, that's much more difficult to put into place.
So I don't think anyone would question that we need to be sensitive to cost, but let's get the whole patient benefit clinical side into this discussion as well. Peter, you provided an example that kicked off this discussion of something where, based on your review of the evidence, there was really no clinical advance. There was just a higher price. But as we heard from the paper presented earlier today, there's a wide distribution of costs and benefits associated with traditional drugs as well as specialty pharmacy drugs. Given that, it certainly appears that there are opportunities for clinical advances that maybe are worth it. So I'd like you to both, I'll start with you, Peter, put on your clinician's hat at a leading institution that treats people with cancer. It seems like you were faced with, I don't want to say it was an easy situation, but a fairly clear situation. When it starts getting muddier, how do you look at it then?
No, and please characterize it that way. In the times we characterized it as a no-brainer, right? But yet it was a difficult thing to do that obviously got a lot of attention. Let me say something about this price-efficacy trade-off. There's sort of two pieces, if you think about it. One is sort of the ambient temperature of prices, right, which is going up every year at a rate faster than medical inflation and probably faster than any other sector of the healthcare economy, about 8% compounded per year for introductory prices in cancer. So they're all, just if you come on this year, you're just going to cost more. Then there's the sort of price against effectiveness or efficacy. And there's weak correlation, if any, but there's spread around the prices. So it's sort of, you don't see either of the two things you would like to see with advances. One would be falling prices like we see in every other sector for same gains, but also some meaningful correlation. Well, a drug that provides a bigger benefit costs more than the one that doesn't. Our example was a no-brainer. It was a drug that was twice as much, which was no better, and actually we thought it was less good, and so that of course is a correlation in the other direction.
You focused a lot on the cost side.
Yeah,
let's bring in
yeah.
the
Well,
benefits.
I think the poster child there is the new hepatitis C agents. They are a tremendous breakthrough. I mean, when you look at the arduous therapy that was available for hepatitis C as little as sort of 3 years ago, before Incivek and Bochprevir came along, the first generation of protease inhibitors, we got about 30 or 40% of patients through it. It was a year-long process, a year of interferon. It was horrible treatment. And it was expensive. The new medications, especially the new orals that are about to come out, are going to be an 8 to 12 week course of therapy for many people. They have very small side effects, and their cure rates are absolutely sort of tremendous. So it's actually, you can extinguish a disease. If you do appropriate sort of case finding, we'll be able to sort of mostly eliminate hepatitis C. And yet the costs are tremendous. And I was interested in the analysis that the Tufts group did, sort of looking at incremental ICERs around medications. And if you look at the pricing around the hepatitis C drugs, they're not outlandish, especially not compared to some of the oncological agents that we're seeing. They're in the same range of $120,000 to $130,000 per quality adjusted life here. But the question is, can you really support that? And when the medication costs far less than other countries, should our country be basically sort of supporting the entire cost of development and the amount of money that's coming in from those medications? Is that more than you'd expect to be a sort of reasonable rate of return? So those are the kinds of things the drug manufacturers have to take into account. I think mostly what they're doing today, it looks to me like they're looking around and they're saying, well, this costs $80,000, that costs $85,000, maybe I'll come in at $90,000. It's kind of the way doctors in the doctor's dining room used to sort of price their services, look left and right, and then, raise it by 5%. That's how we managed to get 5 to 8% inflation in healthcare costs over a 40-year period of time.
More arithmetic. It works pretty well.
Yeah, it does have that impression, and there's actually been a number of pharma executives now that have gone on record, and in fact, and I don't want to talk about Zaltrap anymore, trust me, but in fact, Sanofi came out and they said we priced to what our competitor was, and they actually have been pretty open that they were wrong about what the right dose of Avastin was. So they actually thought that we used twice the dose we did. So it had nothing to do with these other arguments. It was just essentially an Excel spreadsheet mistake. But those things happen, I guess.
So I wanted, I could ask you all questions all day. I really would appreciate you all participating in this discussion. Again, as with this morning, I'd prefer it be question-oriented, but I see one here and one over there, and I thought we had mics at the ready, but I'm not.
While we're getting the mics, let me follow up on what Troy said. We'll get it. But there is it's sort of intriguing to break down the various pharma lobby arguments for the high price of drugs. And sometimes they will argue that drugs are for rare conditions, therefore they need high prices. So Novartis' argument why Zycata costs more than Xalkori is that it's second line. There's fewer patients on second line. It's about $13,000 a month for that drug. But Sovaldi is the opposite case, and so that argument is, oh, well, we're treating a huge unmet need at the population level. So if you will, all roads lead to Oz. All consequences and scenarios can be reshaped to justify high prices.
Yeah, I would follow up on that. A lot of this pricing does follow kind of what would be considered classic orphan drugs. You've got a protein deficiency, and there's a very small number of people, 2,000 or 3,000 people around the country who actually have the disorder. The problem with hepatitis C is that we've got 1.5 million people with and another 1.5 who we know have it but haven't been sort of diagnosed. And next year, we're going to see another 2 medications come on board that are going to be very interesting to watch. Palbol, which is the drug from Pfizer for treating breast cancer, I think is going to spread throughout breast cancer therapy with 260,000 new cases per year. It's going to be a fairly prevalent utilization. And then you look at the PCSK9s, which are an injectable specialty medication for lowering LDL. You could have between 3 and 20 million people being treated with that medication. You multiply that times $10,000 a year, and you're starting to look at a tremendous price tag. So what's happened is this pricing for sort of orphan drugs has sort of basically sort of diffused out into the overall pricing, and you can see that if you look over the last 10 years at the launches, at the costs for new specialty medications at the time of launch.
So I am going to, as we get you in, I am going to say. I don't want the focus of our discussion to be on drug pricing because I think there's knowledge about the inputs to that is not represented here. I'd rather we focus on sort of the patient interface, the clinical side of it, as well as the price at point of care, simply, again, just for completeness, not that we should stay away from tough issues. But let's go ahead. Go ahead.
I represent the other side. So Lisa Wonder-Davis, I spent about 25 years in pharma. Now I just consult back to pharma. But I was going to say there's another side to your input issue, not saying that any particular drug price is justified one way or the other. The evidence suggests that the R&D investment actually did decline in areas where over time the industry decided there was no return. The evidence also suggests that the R&D investment doesn't happen where there's no expectation of return, places like Ebola and other diseases. So my question back to you is two things. One, what are your thoughts about some new financing models for the R&D we hope continues, which is to actually generate more cures of long-term chronic expensive diseases?
You want to take
Peter,
that?
you got that one?
I mean, we had a financing model. It was called the National Institutes of Health, right? So, and that many of these products have come out of that basic research, as you know. But I think there is a challenge between price setting and the long time it takes for development programs to get going. And if we could seek to optimize that by setting prices to needs and also setting prices to gains from therapies, then we would have a much more efficient system than we have right now. I think Pharma's got a press conference, I think, tomorrow. They've got 800 drugs in development for oncology. Right? That's great, and it's great for cancer patients, but we'll probably end up with crowded fields in specific indications and a lot of patients still with unmet needs.
Yeah, I would just say, sort of all good people, everybody trying to sort of do the best. And the pharmaceutical industry, obviously, sort of trying to get medications that are really going to help our patients, and all that's really good. I would say the pharmaceutical industry has been less than transparent about the relationship between sort of the overall development costs and the pricing of medications. It's hard for me, and I try to pay attention to literature, it's hard for me to point out, sort of any salient article that's really gone through that. And that's the way companies tend to be, but the transparency has not really been there. We mentioned in an article we wrote for another journal about the Hep C drugs. At least you could, that Gilead had basically bought another company, so you could, and sofosbuvir had been completely developed almost up to the sort of clinical trial period by that, and so you could say, okay, that's the cost of development. They bought that company, and so that would be the sort of highest cost. You could kind of think about what the costs were for development, and it looks like the return will far outstrip that. So it's very difficult to get that information.
Good. Can you get a mic down to you?
Jack Oadley from Georgetown University. One of the things we've heard a lot about in the last really decade is the notion of the potential role of follow-on biologics or biosimilars. And what I keep trying to think about is what's going to create the incentive for more widespread use of those once they're approved. And so you've got issues like rebates and coupons that could be used to slow their use. You've got things like prior authorization step therapy that could be used to increase their use. There's issues obviously on both sides. You've got the broader issue of just general acceptance by both prescribers and patients. So do you have ideas about how we can sort of look forward and be ready to sort of encourage more use of those and bring that sort of competitive element into pricing for some of these expensive specialty drugs?
I would, we have a paper that's in Revised and Resubmit with Health Affairs on the issue of sort of development of the biologics, and in writing that, went into it kind of pessimistic about how it was going to occur in the United States, but actually now a little bit more optimistic. I think the market is going to sort of respond, and there are going to be biologics available, or biosimilars in a number of classes. And then I think for our process, it's going to be pretty straightforward. There'll be studies of those, and our Pharmacy and Therapeutics Committee will look at those, and if they look like they're interchangeable with existing biologics, then we'll use the variety of different mechanisms we have, most likely formulary, to drive business towards those, because the pricing will come down. Now, we can't say how much the pricing is going to come down. Could be like multi-source brands where we might get a 30 to 40% drop. It's unlikely to be Hatch-Waxman, drop down to those levels, but nonetheless, there will be some relief there. So I'm at least optimistic, especially once the medications are available and the science is out there about how they work, that they will get into the marketplace.
Here.
David Rabin, Georgetown University.
Is there anybody teaching at Georgetown today?
Very different views. Especially drugs are available for the world. Many other countries have access to them, and the specialty drug cost doesn't seem to be pervasive. So I wonder if you would say a little bit about mechanisms that other nations use to allow their population to have access to specialty drugs, but at costs that are not engendering their healthcare systems.
Yeah, it's difficult to summarize briefly, and there's no sort of homogeneous answer, but there is both the sort of pseudo-collective bargaining that occurs, particularly in the Western Europe, and also some very rough authority activity in certain countries like England, and so, or in the United Kingdom, which includes Scotland. So, for example, at the UK, they will set absolute cutoffs, and they'll say, they have national formulary, and there's some twists and turns to this, and there's some carve-outs, but nevertheless, they'll say, we will do a cost-effectiveness analysis in crude terms, and we will cut you off, and if you don't meet the threshold. So many of the drugs, some of which have been mentioned already today, just don't even enter the country, really, at least onto the national formulary. The Germans are also working on a sort of comparative effectiveness kind of baseline payment for some specialty drugs. But the reality is, every market has both buyers and sellers, and these prices seem to achieve these levels because buyers act more collectively for example, in the OECD countries than they do in the US.
I would just add, they are different, and just use Britain and Germany because Peter mentioned those. Britain's going to basically decide sort of what's in and what's not on the formulary, but then they don't really do price control. So, the widely quoted $84,000 for sofosbuvir here, $59,000 there. What Medicare actually is paying here is not AWP, but there's a series of discounts that they put on top of that. It gets it down to about $60,000. So same cost there as here, and they're going to, like Medicare, they're going to treat, unlike a lot of Medicaid programs here in the United States, where people who have hepatitis C basically are not being treated. In Germany, they do run a comparative effectiveness approach, so you get a year of sort of price at whatever you want. But in the meantime, they're deciding sort of what the comparator is. So they may make the comparator for an MS drug, physical therapy or something like that, and then that could drop the price down to sort of whatever the comparator is priced at. So different countries are taking different approaches, but I'd say most of these countries, the UK in particular, is going to be facing the same sort of crisis around increase in costs that we're going to have here with specialty medications.
Yes.
Hi, I'm Bob Rosenblatt. I run a website called helpwithaging.com about Medicare financing. I want to follow up on the last two questions in your comments. Do you think we'll see the emergence of medical tourism where Americans with hepatitis and or forms of cancers will go to other countries to get these therapeutic drugs, presumably at a much lower cost?
I would just be speculating. I assume that insurance eligibility doesn't travel with them into these other countries unless they have citizenship in them. So I think that would probably, but I'm just guessing. I certainly don't have expertise on it. And if we do see it, I suspect it'll be more in the form of news reports. It'll be important moves of the population. It's obviously popular to talk about Canadian drug prices, but the idea that we would, for example, be able to piggyback on Canadian drug prices and import drugs from Canada has been analogized to a hippopotamus sitting on top of a snail. Just in terms of scale, it's unlikely.
We have time for, I see a hand up in the back.
Hi, I'm Dr. Caroline Poplin. I'm a primary care physician. I'm also an attorney, and in full disclosure, I work on QTAM cases for off-label marketing, and I've seen terrible things. Why hasn't anyone suggested a sort of utility approach to, a public utility approach to drugs, where the drug company lays out its costs, including all the drugs that failed before and how long it took, and the salaries of the heads of the company, and then decide, choose a price that represents a 5 or 10% profit, and then you've used, the company has used those failed tests once. You don't get to keep using the same ones over and over and over again in this very obscure, it costs us a lot to develop them. I don't think anyone's ever suggested that, and I don't know why not.
Well, there was a famous political scientist at Yale who had these two different paradigms to sort of muddle through and comprehensive rationality, and I think we could come up with a lot of comprehensive rationality sort of approaches that might make more sense around drug pricing, but we're tending to sort of muddle through. If you come to this town, the government won't even allow you to use comparative effectiveness in healthcare. So, it's hard to say how we're going to get to a more comprehensive structure when we're at where we're at right now. So I think it's a good idea, but I don't think it's politically viable.
Yeah, I thank you for that question. I actually think that the pharmaceutical industry has been stating for a while that they are a regulated utility under the model you've just described, with the distinction that they self-regulate. And I take this from I'm not kidding. I mean, maybe a little. No, but they will state that we set our prices to fuel future innovation because the risks of R&D are high. And they are essentially saying, and we need to have profits. So they are saying, we are seeing our Excel spreadsheet, and we need to price in order to fuel ourselves. And so that is, in fact, the language with the last step missing, which is that the regulator is some other entity.
Let's take one last here, and then I'm going to wrap up with my two panelists.
Hi, my name is Kimberly Beer with Susan G. Komen, and I represent, of course, women and men with breast cancer. And so we're hearing about drug pricing, cost containment measures, hospital and doctor incentives, CER. Patient groups are in a really difficult position to focus their efforts in an effective way for their patients. And I was wondering if you have any advice for us, since we're kind of sitting in the middle here, and both metaphorically and between you right now, and as many of us are setting our legislative agendas.
But my advice is to continue to do what you've been doing, which is to represent groups of patients with particular diseases and ensure that they have sort of appropriate and reasonable access to all the medications that are going to help for them. And I do think in that regard, we do have a fairly rational structure, and that we get good studies that demonstrate, for instance, in breast cancer, which drugs work and which drugs don't, and which drugs are for which stage of breast cancer. There's a mix of medications that are very inexpensive and some medications that are expensive. But I think that the advocacy that groups like yours and others do is very important to the decision-making overall for companies like mine, for the pharmaceutical manufacturers, and for things that are going on in academics as well.
Okay. Well, you've we can take, since that's so close to what was going to be my last question. I think I can squeeze one more in, and without worrying about going too far.
I'm Mark Plaster with the Emergency Physicians Monthly, and as a carry-on question, Peter, to your analysis of what the drug companies are doing, where's transparency and media and exposure of what true drug costs are? Where does that play into making drug companies price appropriately?
Well, I think that's a rhetorical question. I don't really have an answer to it, but I think that there is probably thank you. Anyway, you may have missed my clever retort, there's clearly a role for the drug companies are producing a societal good. There's clearly a role for greater understanding and not taking steps that undermine the progress that we've made. And I think it's fair also to say that this is one of the most important sectors in terms of the improvements in human health we've seen over a very long time period. So the question is, when do we get too far ahead of ourselves? And when do prices, given that there are no constraints on them at all, just rise to a point where we're essentially pouring more fuel on a fire than it needs? I think personally we have gotten to that point. I base that on things like there's a dozen drugs in development for the ALK rearrangement in lung cancer, which affects about 6,000 to 8,000 patients, when we already have first line and second line occupied by marketed products that work. Why would there be so many if there weren't sort of frothy prices?
Any thoughts?
That's right.
Okay. Well, I'm going to use I'm going to ask you to constrain your answers to my last question with in a muddling through framework, because I don't want us to think too blue sky here, although I don't mind it. I want us to be productive. I was just hoping we could end with your thoughts on change in public policy that we could make that would get us closer to the appropriate balance between value and quality and outcomes for patients, as well as the number of resources we can afford as a society to commit to specialty drugs. And again, with the understanding that this has not been a full-blown review of how prices are set, but at the end of the day, we have, as I think you were describing, you have a real patient with a real need sitting in front of you. And what could we do to improve policy that would make you feel that it's more likely that we are in an environment where that patient is the most likely to get the highest value treatment, both in the pipeline of new created as well as given the reservoir of treatments that are available today?
Well, I think two or three things.
Good.
The first is related to both transparency of prices and who the intermediaries are. I think we need to get institutions and doctors out of the business of profiting or losing money on the exchange of drugs. And I promise not to mention the great unnamed hospital program, but also doctors in oncology practices also buy and bill. We need to get them out of that business. It's crippling small practices. It's profiting for large ones. We have consolidation. We have higher insurance rates as a product of that. That's one piece of it. We need to seriously rethink coinsurance. Coinsurance is a tool, as Troy mentioned. We're all well aware of it, but it doesn't achieve all of the goals it should in terms of getting products that work to patients. The couponing is a problematic end around, as I've mentioned, to that. But what we know from the data, we saw more of it today, but we've known this for a long time, as you layer on coinsurance to drugs that work, people stop taking them. At that point, the entire purpose of the enterprise is sort of shortchanged of developing drugs. The only drugs of value are ones patients can afford.
Great. Troy?
Well, I think those are very good points. I would agree. Divorcing from the 340B program, but moving away from sort of Part B distribution of medications, because it just creates a economic incentive through an arbitrage process for the physicians to use the most expensive medications and probably to overuse medications. There's no doctor that's really sitting there thinking, I'm going to make a lot of money on my patient by using these medications. But at the margin, those kinds of economic incentives do work, and they create unnecessary inflation overall. The second place, which Peter's pointed out, in a lot of the other areas of health insurance, Medicare Advantage, some Medicaid managed care, commercial insurance, there are processes that we can put in place to try to drive people to the right medications, but it's not true in fee-for-service Medicare. So I think CMS has to begin to sort of think about, sort of how they can begin to apply some programs that are aimed at ensuring that cost-effective use of medications occurs in the fee-for-service program.
Great. Well, those are very thoughtful proposals that conclude a very thoughtful discussion. I want to thank you both. Thank you also for the support of CVS Health for the issue, and thank you for joining us today.